Thank you for the kind comments and for being invited to give this lecture. I just changed a little bit the title because I do not believe it's enough to monitor heart failure, but what we really try to do with these devices is actually try and prevent a heart failure decompensation. And this is the major topic, I believe. I would like to start off this with a well-known slide which actually says that in more than 120,000 consecutive patients who were enrolled in the ADER registry and Euro Heart Failure Survey, it was found out that up to 75% of hospitalizations for heart failure are due to worsening chronic heart failure. And this is actually an opportunity for us as treating physicians to upstream strategies to detect early signs of deterioration of our patients with chronic heart failure and avert their hospitalizations. This is true in theory, but in practice, despite optimal medical therapy plus CRT, we still are aware of very high mortality and readmission rates of patients who were hospitalized for heart failure. And we have many, many statistics. This is just our statistic in Hadassah, where Israel Gottesman found that actually following 370 patients who were hospitalized for 1 year, who were hospitalized for heart failure, a quarter of them died during a year, 2/3 were re-hospitalized, and only 1/4 were free of these events. And the second principle when we are going to discuss these monitoring devices we have to remember is that most of the time, actually almost all the time, patients are outside our clinics and hospitals, and therefore any monitoring system actually trying to prevent hospitalization has to monitor them at home. And the third principle to remind is that we really don't know exactly what is the best technique of monitoring. And what you can see here is just one of the many meta-analyses showing that if we want to reduce all-cause mortality, hospitalization, or heart failure hospitalization, first of all, we find out that an interactive automatic voice recognition system, which says if you have a heart failure, punch 1, if you don't have punch 2, etc., is completely useless. Nevertheless, when you compare a simple technique, like a telephone call coming from a nurse specialized in heart failure, who follows patients who are well known to her, and a complex telemonitoring system, are both very effective in meta-analysis studies on all endpoints you can see here. What is more effective, I really don't know, but I have a hunch that actually it's very, very hard to win the competition with a knowledgeable nurse. And we really, this is our experience again, which we published in our first 350 patients who came into an outpatient specialized heart failure centers in which implementation of the therapy is led by specialist nurses. Our patients, 350 patients, were compared with 6,000 patients in the area of Jerusalem belonging to this HMO, and by all parameters, the 350 patients who were enrolled in our program were sicker and than the population, general population of patients with heart failure not belonging to the heart failure center. Despite of that, we found that there was an exactly similar, very similar mortality rate between the two groups, and actually the patients belonging to the heart failure center had a decrease in 35% of hospitalizations for heart failure as compared with the overall group, and the belonging to the heart failure center in multivariate analysis actually came out of as one of the predictors of preventing hospitalization. So when we discuss now the remote monitoring approaches, I would like, in the short time available, because it's a huge literature going on that, to discuss those related to symptoms, blood pressure, and weight evaluations, those in which in implanted devices, CRT or RCD, based parameters were used, like intrathoracic impedance, but not only intrathoracic impedance, and implanted hemodynamic monitors. I will give you a very short review of Israeli devices which are investigated as non-invasive assessment of congestion, and we probably won't have time for the biomarker studies. So let's start off with the studies based on clinical parameters, symptoms, weight, and blood pressure. The first one was the tele-HF study, in which more than 1,600 patients were enrolled using a telephone-based interactive voice response system, in which symptoms and weight were recorded. And as we can see, there was no difference in death, readmissions, or combined parameter of these two variables. The second study was with a different approach, in which in 700 patients, symptoms, weight, blood pressure, and ECG, transfer from ECG, were collected in patients with a left ventricular ejection fraction of less than 35% and hospitalization for heart failure, or left ventricular ejection fraction less than 25%. And what was found in this very well organized study, in which the data were automatically transmitted to a telemedical center, which was backed up by very significant means of transportation to from transportation to the hospital, to special hospital beds and teams, including connections with the family physician and treating cardiologist. After a median follow-up of 26 months, was found that there was no difference actually in all causes of death, or cardiovascular death, or hospitalization, which were the primary endpoints of the study. This was quite disappointing, but it shouldn't have been so, because actually we know that symptoms are really not a very good indicator of deteriorating heart failure. And in terms of the weight gain, the sensitivity in different studies was found to be as low as 20%. So we really cannot completely rely, even if we would like to rely on symptoms. How about measurements in implanted devices, CRT and ICD? So the basis of this approach is actually the very encouraging finding by different techniques that lung congestion clinically actually starts about 2 weeks prior to symptoms. So if we have this time delay and we can detect the lung congestion prior to symptoms, we really can intervene. And this is one of the more renowned studies by Adamson and co-workers, where they used the device and found that actually the right ventricular systolic pressure and the estimated pulmonary diastolic pressure started to raise several days prior to occurrence of symptoms and hospitalization for heart failure. The same was found for intrathoracic impedance measurements, and what was found here actually, that there occurred a decline in impedance about 2 weeks before onset on symptoms and admission for heart failure, by improvement of the conductivity, of the electrical conductivity of the thorax due to the accumulation of the fluid in the lungs. And then came, based on this very encouraging data, came the .HF trial, much awaited .HF trial, in which the primary endpoint was all-cause mortality and heart failure hospitalization in 335 patients in whom the optimal system of the Medtronic company was used in order to evaluate bioimpedance and guide therapy. And what happened, that the study had to be stopped prematurely because of excess events in the excess arm compared with the control arm. And this was not due to mortality, which was very similar in the two groups, but to excess of 80% in hospitalizations due to heart failure for different reasons, which I won't discuss now. And then finally came at the last ESC meeting in Amsterdam, the InTime trial. This trial was a randomized controlled multicenter trial in which 660 patients with heart failure lasting for at least 3 months in class 2 and 3 New York Heart Association, and reduced ejection fraction had either an ICD or CRT, and they were followed by telemonitoring primarily for symptoms and arrhythmia burden. This is a study done primarily by electrophysiologists. And what was found that there was a significant improvement in symptoms in the interventional arm as compared with the control arm. But the major finding of the study was that there was a 65% decrease in mortality and a 64% decrease in cardiovascular mortality. So indeed, Dr. Hendricks could proudly announce at the hotline session in Amsterdam that this is the first implant-based remote monitoring randomized controlled trial demonstrating significant benefits of implant-based home monitoring for patients with advanced heart failure and home monitoring-based detection of changes in clinical status or technical events can trigger medical actions that prevent worsening of heart failure. This study had not been yet published to the best of my knowledge, and all we have available is the abstract and presentation at the ESC. And now, what about sensors and hemodynamic monitors, which are extensively investigated? And this is only a partial list of all the sensors and hemodynamic monitors evaluated, including heart rate derivatives like heart rate variability, accelerometers, impedance monitors, I just gave you some, hemodynamic monitoring, cardiac output monitoring, or emerging modalities like biomarkers and metabolomic signaling cascades. I will just show you here the very few of these studies, like the first one being the successful champion trial, in which the CardioMEMS catheter-based delivery system was used in order to deliver a pressure sensor into the pulmonary artery, which transmits online continuously, if required, measurements of the systolic, diastolic, and mean pulmonary artery pressures, and in accordance with the findings, there is intervention and change in therapy. And what had been found was actually a 35% decrease in admission rates and 30% decrease in admissions or survival of the patients in this study. Despite the successful outcome of the study, however, there is no FDA approval for the use of this device in everyday clinical practice. The second device which had been delivered was, and caused quite a lot of enthusiasm, was this physician-directed patient self-management left atrial pressure in advanced chronic heart failure. Two approaches were here actually evaluated. One was the system itself, and the second, a quite special approach in which the information which was delivered by the device actually was delivered to the patient himself, who had to change the therapy according to a previously decided algorithm in which the treating physician actually put already in the data what has the patient to do in accordance to the results which will be received by the device. We are dealing here with a special device in which we have a cold antenna which is put under the skin. It does not belong to the ICD. It's an independent device. And then we have at the end of the lead, we have this sensor which actually is located on the left side of the interarterial septum and delivers measurements in the left atrial pressure to a patient advisory module. And here will come the information. The patient will push a button and will say, okay, now you have a 25 millimeter mercury left atrial pressure, increase your diuretic dose from 60 to 120 milligrams per day, and the patients should improve. So what was the finding? The finding was the device was safe and the medications were altered in accordance to the module in a very effective way. New York Heart Association class improved by 0.7 class, LV ejection fraction increased by 7%, and there was a low risk of admission due to acute decompensated heart failure. However, this was published in 2010. This is a feasibility study basically, and you might be aware of additional data coming on the way, but at least I am not aware of additional publications which this really exciting modality I would have anticipated after 3 years should come out with. And now let me finish my talk. I am trying to be in time at this late hour. Quo vadis, and I would like to give you only a small insight, and I am personally aware of at least 4 additional Israeli companies which did not publish yet their data, but they are working very intensely on trying to improve heart failure monitoring in an ambulatory basis. And these are only 6 companies of which all published initial or more advanced data, and of which I will spend about between half a minute and 1 minute to present all of them. So the first one, and probably the oldest one, is the Cheetah company, which actually uses what is called a phase shift technique, by which alternative current shifting occurs when it is delivered to the chest wall and through that to the thorax. And it turns out that there is a tight correlation between the shift in the alternative current and the amount of fluid in the lungs. Therefore, and the stroke volume, and the stroke volume. Therefore, this technique is used primarily for stroke volume and cardiac output measurements, particularly in intensive care units all over the world. It's commercially available. The Kima microcore, it's using a continuous remote monitoring of the thoracic fluid using body penetrating radar electromagnetic technology, which provides early warning of up to 7 days of pulmonary congestion prior to occurrence of symptoms. Its accuracy has been proven in intermediation techniques, is used now, evaluated in clinical and preclinical trials, both in all kinds of facilities, including from hospitalized patients, intensive care patients, daycare patients, and outpatients. It has a CE mark, but it's CE mark, but no FDA marking. Using the same technique of radar electromagnetic fields is the Sensible company, who actually have a proprietary monitoring and imaging technology, and in which the principle is that the fluid replaces air, and there is an increase in the dielectric coefficient in the thorax and in the lungs, so they are lung specific, they claim, as opposed to other modalities which we'll see also claim to be lung specific, even if they give here bioimpedance as being thoracic specific and not lung specific. And it enables non-invasive and continuous monitoring of lung fluid concentration. I am aware that they are going to finish shortly a clinical study in which patients were dehydrated after they came with acute decompensated heart failure into the hospital, and then here we can see their measurements, which are in the safe zone in a patient who remained asymptomatic and stable, as compared with a patient who, after hospital discharge, actually the measurements which were not known to the treating physicians were out of the safe zone, and the patient later on actually had to be readmitted. NI Medical, it's another commercially available system in which whole body impedance cardiography is performed. They do not measure pulmonary congestion, but whole body impedance cardiography gives us information on stroke volume, cardiac output, total peripheral resistance, and total body water, both in and out of the hospital. And at least in this publication coming from Japan, it was claimed that it is the only technology that is within the boundaries of the FDA guidelines of bioequivalence. Nevertheless, this statement was made quite a few years ago, when most of the of the devices I discussed today were not available yet. RS medical monitoring of Dr. Shohat is actually probably the most investigated device in which we have hundreds of patients enrolled in any part of and any aspect. He tried to evaluate, and after all these very extensive studies, he found, if I want to conclude very shortly, which is really a task, and to say that he found reduced acute heart failure decompensations after acute MI during hospitalization of the patients for acute myocardial infarction, reduced in-hospital and 6 years mortality after acute myocardial infarction in those who used this system for supervision, and reduced by 50% rehospitalizations for acute heart failure, and by 40% heart failure deaths in out-of-hospital setting in congestive heart patients, which is far more than we can say using today, for example, biomarkers. And the last company, which I have to say that I am its medical advisor, is actually using what is called parametric electrical impedance tomography, a special technique developed by Professor Aboud in Tel Aviv University, in which determines fluid levels in each lung in isolation from other organs in the thorax, evaluates conductivity. This is the claim at least. And it showed a good correlation with congestion in an animal model in which transpulmonary thermodilution valve was used. Here you can see the pulmonary edema being induced in 6 animals, and in the meantime, when evaluated, the parametric electrical impedance showed gradual increase in conductivity at levels of mild, moderate, and severe congestion. And in addition, good correlation with clinically defined pulmonary congestion in pilot clinical studies was found from no congestion to severe congestion in this system, which is going to be now again clinically investigated in a pilot study. If I want to summarize, I really believe that remote monitoring is a very promising technology, and it's almost an obligatory technology today, but we still need to learn a lot because we have some unmet needs and unanswered questions. We still do not know which are the best parameters to be monitored. What are the best algorithms to avoid TMI, which is too much information, and alter promptly therapies if indicated. We do not know who should be the receiver of the information and in charge of changing in an effective way and safe way the therapy. And we do not know what is the appropriate nurse-to-patient ratio, in other words, number of nurses needed to treat our patients. Thank you very much.
Thank you very much. Very elegant talk, very elegant summary of a very timely topic. The lecture is now open for questions. John?
What about the correlations of these parameters, impedance and biomarkers, for example, BNP? Is there a good relationship or not?
Yes, there is all the impedance studies used also biomarkers as so-called gold standards for the condition of the patients. Actually, the correlation is quite good in most of the studies, but not all. In most of the studies, the correlation is good. Certainly it's good when you have a patient with very severe congestion or no congestion. But in the middle, there are discrepancies between the two.
The one question, conceptually, all these companies, all these technologies you referred to, they are based on the concept that what you need to monitor is actually to predict, decrease the risk, etc., is to monitor congestion, fluid overload, etc., etc. In your opinion, and I'm sure that my co-chairman has also very strong feeling that this is the only biomarker parameter you need to monitor. Perhaps you need to think out of the box and monitor and evaluate something else, I'm sure that you have a strong feeling and experience on that, because everything is based on a kind of a congestion-related parameters to be monitored, whichever technique we are using, just for my curiosity.
Actually, I should allow Professor Shofa to sit behind you, John, who is the one who developed, but I answered briefly. We studied over 1,000 patients. When I came to the department, he was already working on it, and I was quite skeptical. But we found that we detect initially in acute MI at least an hour or more. No other signs could show any signs of congestion. After several hundred, we started to prematurely treat, and we avoided further deterioration. We didn't have for all of them, but we have a sub-study with quite a good correlation to BNP. So there is a correlation between this and BNP. Actually, we checked it all over the gamut. Acute MI, acute heart failure, decompensation, and chronic heart failure. Michael, do you want to add a little bit?
But before you answer, I remember that why don't you come to the microphone on the back a little bit? I interviewed Gerd Hendricks on this in time, and I asked him, Gerd, is this a hemodynamic thing? And he said, no. Actually, the death risk reduction is in the arrhythmias. It's not in a volume of the load, etc., etc. It's in the arrhythmias. So they have a completely different approach. But please, Karen.
I will answer the man what I think.
I want to add some information about your first question. This kind of monitors, I cannot say about all, but about congestion monitoring, they help me today in really everyday practice. I know what treatment is better and on the side. And in application to cellular study, I thought about to use kind of this kind of monitoring to see if you have successful decongestion or no. It's each measurement only 1 minute, and you have a real information. Is it better or worse?
Thank you.
So this is a very short comment for someone having something like 1,500 patients evaluated by the technique. So let me, because we are just starting a pilot study on this, so to tell you what I really believe. I believe at the end of the day, we are trying, it depends what you want to achieve. If you want to achieve survival, I am not sure this is the technique to go, and probably a simple electrophysiologist, sorry for the word simple, can achieve more. But if we want to improve quality of life of the patients, and this is what is here important, and to avoid hospitalizations, I really believe that this avoiding congestion is a major part of the approach. And whether it is enough only to measure lung congestion or overall body congestion, or both of them, it's really a question which can be discussed. And probably at the end of the day, if we will have a very easily available biomarker which you can have on the spot together to combine it with this type of congestion marker, and then decide about the therapy, probably will improve our approach to the patients, with the major aim again to improve quality of life and avoid hospitalizations.
If I may, we have today, thank you, Andres, we have today an excellent review of all the modalities with acute compensation, including surgery, but which, if we can conclude with you, the best treatment of acute heart failure is to prevent.
Okay, so thank you very much.
Thank you.